to walk away. The answer is for the United States to double down and make sure that any grievances we have are addressed. Otherwise, the problem for which you are identifying is exacerbated by the United States not being at the table with the WHO. And while the major donors to that organization certainly have lots of influence, as is the case with every international organization, it is it is a oversimplification to suggest that they are in the pocket of the Chinese government. China has influence. The United States has influence as well, so long as we are at the table. I have two areas to cover, and the first I wanted to raise with you, Dr. Collins, and that is around the budget request to double the firearm injury and mortality prevention research account. Let me place myself solidly behind that request. Thank you for making it, and I was hoping you might, I apologize if you've gotten a question on this already. I've been listening, but in and out a bit. Hoping that you might be able to talk a little bit about how you might prioritize that additional funding, especially as it might relate to research on community-based interventions and what works and what doesn't, and then how to make sure that all that information gets out to community partners, folks who are boots on the ground, maybe not the exact set of players that NIH is used to disseminating information to.
Well, I appreciate the question, and we are enthusiastic about expanding our approach and the amount of funds we can put into research on firearm violence. After all, some 40,000 deaths happen each year from firearms. About 60% of those are suicides, which is another topic that came up earlier and is also part of our suicide prevention, is to think about availability of guns. I think you're right, though, that community approaches are very much ripe for this kind of approach, where you might not just try to change one thing in the community, but see if by coordinating the efforts across multiple different ways, in terms of making sure that firearms are not accessible to those people who might misuse them, in terms of particularly adolescent and youth risks of violence and how to intervene. Maybe we could take an approach that would be more holistic as opposed to trying to fix one thing at a time. With a larger amount of funding here and a community focus, I think we might be able to do that.
The president has proposed, I think, $5 billion to support these community-based interventions. Maybe some of that will be used for assessment and study, but given the fact that I think we probably can get bipartisan agreement about supporting these investments in prevention, really would be helpful to use some of this increased funding to assess which ones work and which ones don't. Second broad topic, and maybe I'll address this both to Dr. Collins and I think via video, Dr. Perez-Stable, is on the topic of the social determinants of health. And I'm just interested to hear a little bit about how we've adjusted research based upon our growing understanding that people's health is dictated by where they live and how much money they make and how close they are to pollution sources. My sense is that this is not an easy sort of thing to incorporate into a research community that is sort of used to working in labs and not always used to thinking about how factors outside the body impact health. What have we learned? How has that changed the way that we fund research and encourage applications to come to NIH that might support social determinant research?
I'm going to ask Dr. Perez-Stable to respond.
Thank you, Dr. Collins, and thank you, Senator Murphy, for that important question. At the National Institute on Minority Health and Health Disparities, and throughout NIH, the topics of social determinants of health have always been present. We consider self-identified race and ethnicity and socioeconomic status with standard measures to be fundamental factors that influence health in ways that we don't really understand. And that's why we believe that all research with human beings should measure these routinely and follow them. In addition to these two, though, there are other demographic and individual social determinants of health, of which many are issues related to age and gender, sexual orientation, but then structural social determinants of health that you referred to, where one lives, plays, and prays, related to both transportation, housing, and issues around green space, and of course, internet access, which has become incredibly important, as we know, in the last year. So we have these fundamentally incorporated into our standard research, and community engagement is really part of everything that we do at NIMHD and increasingly across the agency.
Well, thank you for that. I appreciate the new focus you're putting on this. Again, this is an area of potential bipartisan agreement. Senator Sullivan and I have legislation in this space and look forward to working with you on it. Thank you, Madam Chair.
Thank you. Senator Shelby, are you ready? You want me to?
Yes, I'm ready.
Okay.
I just got here. Thank you. I've been in another hearing